Eileen is an associate member of the GI Medical Oncology Service at Memorial, New York, an associate professor at Cornell. She actually trained in Ireland and then must have been a fellow at Memorial, and then they snapped you up the way they do sometimes. So that's a good sign for you and for them. Eileen's work is, people who work in pancreas cancer are either really passionate or crazy, or both. That's what I've been told, and I think it's probably true. And Eileen has really made some very important headways in translational medicine and pancreas cancer. And are her slides coming? Oh, they're here. Eileen's going to speak about biomarker-driven treatment strategies in pancreas adenocarcinoma, fact or fiction. So you're going to do it. There we go.
Yes, thank you. So thank you very much for the invitation. It's truly a pleasure to be here on a beautiful spring day in Toronto. Beats sticky New York, so thank you. And as Dr. Gallinger mentioned, my focus is pancreas adenocarcinoma, and hopefully the crazy part of it doesn't apply, but passionate, yes, about this disease, and hoping that we can make some strides in terms of trying to direct therapies for individual patients, which has been sort of the holy grail in this disease, and so far I would say is not a practical reality, but there are some hints on a broader basis and on a very focused basis that we might be able to begin to do that. And I'm going to take the liberty, just because I realize the audience is somewhat broad, to discuss a little bit about pancreas cancer in general, to highlight some of the active areas in terms of novel therapeutics, and then for the latter part of the talk to focus on biomarker-driven therapies in pancreas cancer. So this slide sort of summarizes the synopsis of the disease in North America. It's anticipated that there'll be a little over 40,000 patients, and you'll see that the incidence rate near approximates the mortality, just emphasizing the challenges of this disease. And it's reflected another way if you look at where pancreas cancer ranks in terms of incidence with regard to leading causes of cancer and where it ranks on the mortality list. If you take the average person diagnosed with this disease, their expected 5-year survival is in the low single-digit %, but that sort of belies that there are subsets, in particular the group with localized disease who are surgically resected, that have a reasonable potential for 5-year survival, particularly if they've small, well-differentiated node and margin-negative tumors. And fortunately, our individual risk of developing pancreas cancer is very low. And one of the areas in terms of research is trying to identify who might be at risk of this disease. And we'll sort of circle back to this toward the end in terms of the genetics. And this is where there is sort of potential for perhaps making some inroads in terms of earlier detection. So to set the scene in terms of advanced pancreas cancer, this is a study that was presented 2 years ago now and has become pretty ingrained in clinical practice in Europe and in North America and other parts of the world, including here. And it looks at a combination cytotoxic regimen of all our favorite drugs in GI oncology with 5-FU, irinotecan, oxaliplatin, and a modulator leucovorin. That's FOLFIRINOX, the acronym, and compared to gemcitabine, which has been the here today's standard treatment for patients with advanced disease. This study was restricted to patients who had an excellent performance status, and it has a unique distinction in the history of trials in pancreas cancer in that it was stopped early, not for futility, but actually for efficacy. And this is the Kaplan-Meier plot of outcomes. And it's just to help benchmark for the future part of the talk. And you'll see here that there's an incremental survival improvement for FOLFIRINOX compared to gemcitabine for fit patients with advanced disease. And that's certainly the biggest increment that's been observed in any therapeutic trial in this disease. Looking at the downsides, this was balanced by the fact that, as you might predict, more drugs, more side effects, and predictably so, more rates of low blood counts and risk of infection, low platelets, neuropathy, and GI toxicities. Part of that can be ameliorated with patient selection, not giving this to an individual who has significant comorbidities or an impaired functional status. And you can see that there was an internal consistency in this study in that the response rate, so the ability to shrink the cancer and the control of the disease, were also convincingly improved with this regimen. So this is now being integrated into treatment of pancreas cancer in all stages of disease. So for patients who've undergone surgery, a European study is open to accrue patients comparing this regimen to gemcitabine in the postoperative setting. It's now become part of standard treatment in metastatic disease, and at the ASCO meeting this weekend, we're going to update our own experience, which is pretty favorable and supportive of what the original group had presented. Of potential attraction also is that it's going to be integrated into patients who have localized disease, and including this borderline category where there may be a potential for future resection. But a lot of questions remain to be answered. Can you combine this with other agents? And what's the benefit of this 3-drug combination? It's really 4, but 3 cytotoxics. And whether there's a gain in terms of using a 2-drug combination that might have similar outcomes, but a more favorable clinical toxicity profile. So the second just combination of reference that's emerging in this disease is looking at nab-paclitaxel, which is a taxane derivative. And this was a very selected phase 1, phase 2 study for patients with metastatic untreated pancreas cancer. Primary goals were defining the doses, but also obviously looking preliminarily at outcome. And again, a sort of a theme that's emerging of late is for selected patients, you can get survival which approaches a year, and that's in contrast to around 6 to 7 months with gemcitabine, depending on your particular patient population. There was some very nice correlative questions built into this, in particular looking at a preclinical model of this combination based on data from Ken Olive and David Tuveson's group in the UK, which suggested that you can facilitate improved drug delivery and greater levels of cytotoxics by perhaps depleting the stroma and enhancing drug delivery and altering the vasculature. And in addition, there was a suggestion, although this has provoked a lot of questions, that SPARC, or secreted protein acid-rich incystine, a potential biomarker, may be associated with improved outcome. And this was true for SPARC in the stroma, not SPARC in tumor cells. So that is being prospectively validated. And in fact, a large phase 3 trial has completed recruitment earlier this year, comparing gemcitabine and nab-paclitaxel to gemcitabine on its own, and we'll have data probably within the year. And that's a potential practice-changing regimen and may have an additional attraction over the FOLFIRINOX in that it may be feasible for more patients. So we'll see. But these are 2 areas that are at least great interest to medical oncologists in the field. So moving a little bit to the genetics of pancreas cancer, this is a schematic for how pancreas cancer may develop from a embryonic state through progressive stages of pancreatic intraepithelial neoplasia through invasive carcinoma here on the right. And modeling from the Hopkins group has suggested that that process may actually be of the order of a decade to 2. However, in practice, we really only identify patients when they're here, and we have very little opportunity in terms of diagnosing pancreas cancer at the pre-invasive state, except in certain very selected settings, and this goes back to the screening potential of the disease. I know this list is hard to read, but really the only point to make is that there's a cumulative and large number of genetic mutations that occur in this disease, and it may be part of the reason that pancreas cancer is relatively resistant to all forms of treatment. Excuse me. Oops. Go back this way. So before the analysis of the pancreas cancer genomes, the common mutations that were well recognized were P16 occurring in about 80%, mutated KRAS in 90% plus, although there's some sense that that may be actually a little bit less frequent than was originally thought, and there's also some sense that that might be a subgroup of people with pancreas cancer that maybe have a better outcome and maybe people who would be candidates for certain targeted therapies. SMAD4 in the TGF-beta pathway is mutated in a high percentage of people with pancreas cancer, and there's some data from the an analysis of an autopsy series from the Hopkins group and their colleagues, suggesting that progressive loss of SMAD4 may predict for a more biologically aggressive phenotype. And there are a number of groups, including ours, trying to see if we can validate that and whether SMAD4 might be used as a biomarker for therapy which is more directed at local regional control. So, for example, patients with localized, maybe unresectable pancreas cancer could be suitable for both systemic therapy and chemoradiation if their SMAD4 is retained. And for those that have lost a SMAD4, they may be better served by continuation of systemic therapy and avoiding some of the toxicities of combined chemoradiation. So a concept that's coming to the clinic, but it'll be some years if the hypothesis holds as to whether or not we'll have data to make decisions. So this is the landmark paper that was presented in 2008, looking at an analysis of 24 pancreas cancer genomes. And there are a couple of key points to make. The average number of genetic mutations per cancer was about 63. The average number of driver mutations were about 8. And to a certain extent, there was a lot of heterogeneity, but also there was a lot of homogeneity in this analysis, in that most of these mutations occurred in around 12 key signaling pathways that are important in pancreas cancer. And many of these pathways are actively being targeted from a therapeutic perspective, and I'm going to pick up on the hedgehog signaling for a moment. Just to circle back here, these are individual genomes, and these are the genes affected that are belonging to certain of these pathways. This particular one, in that 24 analysis, there were 5 that had belonged to families that had pancreas cancer, familial pancreas cancer, and this particular one led to the identification, along with Dr. Gallinger and others, about PALB2 being a potential risk for developing pancreas cancer and possibly breast cancer too, and also being a possible therapeutic target. So this is a very incomplete list of what's going on in advanced pancreas cancers, just illustrating the pathways and the drugs that are being utilized. And I'm going to illustrate 2 of these from for we do have some data, and 2 others where there are studies ongoing and data is awaited. So an area of particular interest to us has been PSCA, and this sounds like a misnomer, but it stands for prostate stem cell antigen, which is pretty highly expressed in pancreas adenocarcinoma and almost ubiquitously expressed in prostate cancer. In preclinical models, there's data indicating that combining a monoclonal antibody against PSCA with gemcitabine provides a potent decrease in metastatic burden and delay in emergence of metastasis in one of the most robust preclinical models of pancreas cancer. And that's prompted a randomized phase 2 trial that we were heavily involved in, looking at combining this antibody to gemcitabine for patients with advanced disease untreated. There was a 2-to-1 randomization in favor of the experimental arm. This was a non-blinded study, and the main goal was to see if disease control could be improved for longer. And these are the outcomes. There were a number of observations. So firstly, the study did meet its primary endpoint, and this is going to go on to a randomized phase 3 trial, but with a lot of work still to be finalized in terms of where the cutoff of PSCA might stand. The main observations were that people who did receive the antibody fared better, but people's tumors who had PSCA expression also appeared to fare better. So it appears that it may be both prognostic and predictive in pancreas cancer. We'll circle back to this topic again in a moment. And again, sort of a hint that there may be groups of people where you could think about selecting therapy. And a big discussion for the design of the phase 3 is whether we will restrict this to people who have expression of the antibody or not, and whether the data is robust enough to support that at this point. And I think that's still not an answered question. So moving to the hedgehog pathway, as many are aware, this is a developmental pathway. It's involved in nerves and teeth, GI tract and lungs, and is also particularly important in the development of pancreas cancer. And while in contrast to medulloblastomas and basal cell cancers, mutations in this pathway aren't seen in pancreas cancer, or at least haven't been reported to date, but overexpression of various components of the pathway are very common in this disease. And there's a very strong, again, preclinical model from Kel Olive suggesting that using an inhibitor of this pathway, cyclopamine, and IPI 926, it's an affinity compound, that there may be an ability to break down this sort of dense stromal matrix fibrotic reaction that pancreas cancer engenders as it grows, particularly in the primary tumor, and there may be potential for improving drug delivery. In terms of clinical trials, there's a whole series of trials underway, but one has to cause pause at this point in that the initial study has suggested that the hypothesis may not be as strong as was originally detected. This study was in patients with metastatic disease, combining gemcitabine to the hedgehog inhibitor, or more correctly, a smoothing inhibitor. And indeed, there wasn't any obvious benefit in terms of the experimental arm. Part of the concerns are that this pathway may have greatest relevance to patients with localized disease, patients with locally advanced unresectable pancreas cancer, and data looking at that population is going to be quite a while to come. Those studies are just starting. At the ASCO meeting this coming weekend, there will be data presented on the Genentech smoothing inhibitor, and I think this will carry a lot of weight, the combination of these two studies, as to whether there will be continued development of these drugs in pancreas cancer, again, despite a lot of preclinical promise and strong preclinical data. So now moving to biomarkers and pancreas cancer, just our universal resource these days is Wikipedia, and I think it sums it up nicely. So a substance whose concentration can give us a prediction of what the disease status would be. And you can look at this in terms of the drug, you can look at it in terms of the patient, you can look at it in terms of the tumor. And themes that have come up in Dr. Rem's talk earlier today, it has to be accurate, it clearly has to be reproducibly measured and reliable for this to come into clinical decision making. And mostly when we think of biomarkers in terms of treatment, we're talking about molecular biomarkers. So two other points in terms of the distinction between prognostic and predictive. Prognostic implying that you can indicate what a patient's outcome might be based on a certain characteristic, and an example of this is BRAF in colon cancer, mutated BRAF predicting for a poor prognosis. And a predictive marker is an indicator that might suggest either sensitivity or resistance to a certain agent. And again, using the analogy of colon cancer, KRAS is the biomarker du jour, where we don't use anti-EGFR-based therapies for people who have mutated KRAS because of inefficacy and subjecting patients to toxicity. So moving now specifically to pancreas cancer, in terms of validated biomarkers for clinical decision making, if one is honest, one has to say there really are none that are here in terms of today, although there's one in late stage development and a second that's an emerging theme that we'll sort of highlight. But these are some of the candidate biomarkers that are being looked at. Even CA19-9, which has been around a long period of time and routinely measured, is not considered a biomarker for making a decision, although it often does support outcomes in this disease, but not robust enough that we would make decisions on this biomarker in isolation. So moving to treatment and where this stands, this is a schematic of how gemcitabine, one of the main drugs that we've discussed in pancreas cancer, is utilized. It's a prodrug. It's transported intracellularly primarily by the concentrative nucleotide transporters, in particular HENT1, or human equilibrative nucleoside transporter 1. It then undergoes a series of phosphorylations through mono, di, and triphosphate, and it's the...
Attention, please, with Dr. Madhu Cherry, please call locating. Attention, please, with Dr. Madhu Cherry, please call locating immediately.
Okay, so we'll continue here. So the triphosphate moiety is the active metabolite that causes mass chain termination and inhibition of DNA repair. So in terms of gemcitabine, there's a lot of data suggesting that if you manipulate HENT1, you can make cells resistant to treatment. And it's pretty clear that levels of the transporter protein correlate with sensitivity. So for example, patients who have high levels, the drug can be transmitted intracellularly and has a chance of working. Patients with low levels have a higher chance of being resistant. And that's the hypothesis. So in terms of clinical data, there's a lot of retrospective data supporting this, that if you look at surgical series where patients have undergone resection, patients with high HENT1 appear to have improved outcome, and similarly in the advanced disease setting. There are also other biomarkers related to gemcitabine metabolism, including deoxycytidine kinase, for which there's data too that suggests that looking at this level may predict for outcome with gemcitabine. And moving to the clinical arena, this is, there's now a validated test for this by Ventana and Roche, and you can see that it's membrane staining and highly positive in a patient where there's a lot of nucleoside transporter proteins present. So one of the postoperative adjuvant studies in pancreas cancer looked at comparing gemcitabine to 5-FU. There was radiation in both arms, but the main question was, is gemcitabine a better drug given in the postoperative setting? This was done, this trial was prospective, but samples were collected and then analyzed retrospectively. And samples were classified as either no HENT1 expression, low or high HENT1 expression. In this particular sample set, there was about a quarter that didn't have any HENT1 selection. And these are the outcomes. It does look like, at least in this retrospective analysis, which supports the other series, that for patients who have a high HENT1, where presumably gemcitabine is getting in there, and this is the gemcitabine-treated population, their outcome was significantly improved. There was a suggestion, too, in terms of fluoropyrimidine-treated patients that there might be an improvement if they also had a high HENT1, but that did not meet statistical significance. And the overall conclusion from this is that HENT1 level looks to be predictive, but does not appear to be prognostic for outcomes. So this has generated a lot of clinical interest in terms of the possibility that there may be a subset of patients within the gemcitabine-treated population who could be highly sensitive to this disease and to this drug. And we certainly see this clinically, and to date there hasn't been a lot of insight into who those patients are, that they can go a year or two with metastatic pancreas cancer on single-agent gemcitabine and have both a significant response and durable treatment control. And it would be nice to know that. So this is gemcitabine here. This is a new drug. It's called CO101, which is a long lipid moiety here that makes for increased lipid solubility and transmembrane transfer. And this drug gets into cells independent of HENT1. So you can see that there could be a putative advantage for patients with low HENT1 level for this drug over gemcitabine. And preclinically, this looks to be more active than gemcitabine. And this has prompted 2 trials. The first one has completed, but there is no data yet. And it's comparing gemcitabine to CO101 with the primary endpoint to look at survival in the population with HENT1 low. And you might expect that if gemcitabine isn't getting there, CO101, if the hypothesis holds, is going to have the superior outcome. It's also looking in the HENT high population, which there may not be a difference, but preclinically the suggestion is still it should favor CO101. So we'll see. That study has completed recruitment, and we should have data before the end of the year. And this may be practice changing on 2 levels, one in terms of treatment selection, but the other in that it's going to bring the concept of needing to have routine tissue available for people with pancreas cancer in order to make a decision. So right now, for most patients, they have their diagnosis of metastatic disease made on a small FNA, and usually we don't do much more with that. Usually there isn't much more tissue to evaluate. But this and the other topic that I'll come to in a second will suggest that maybe we begin to need to do this, and this is potentially a paradigm changing process in pancreas cancer. We have another small study underway, which is looking at people whose disease just blows through gemcitabine. You would suspect that there are people who have HENT1 low and thus may be resistant on the basis of just the drug not having a chance in the first place because it's not getting there, simplistically put. And the idea is to look at, in that population of patients, whether or not the same medication has a potential value. So this is increasingly a niche population, as now most patients are receiving multi-agent cytotoxics based on the initial part of the presentation. So for the last 10 minutes or so, just going to focus on familial pancreas cancer, where that fits in terms of the whole disease and the therapeutic opportunities that surround that. So just to put the problem here in the perspective, it's estimated that about 10% of people with pancreas cancer may have a genetic predisposition. So of that 44,000 people diagnosed, perhaps around 5,000 will have some familial component. And there are really 2 groups. The biggest group is people in whom, or families in whom we see that there are multiple people infected, and the very classic and public example of that is former President Carter's family. 3 of his immediate family members succumbed to this disease and he did not, but the genetic understanding of that is not unknown. The minority of patients with familial pancreas cancer, there are well-defined genetic syndromes, and these are highlighted here. And these account for several % of people who are diagnosed with pancreas cancer. The most relevant in terms of our discussion today is going to be focused on BRCA1 and 2. So these genes predict for an increased risk in pancreas cancer. BRCA2 has been well recognized, and it's thought that the risk is maybe 3.5 to 10-fold higher. And if we look at just the group of people who have familial pancreas cancer, looking at it backwards, about somewhere between 10 and 17% of them will have an underlying BRCA2 mutation. It's been hinted at, but more recently I think the literature is pretty convincing that BRCA1 is also associated with pancreas cancer, but the relative risk is probably smaller. So what does this mean for these carriers? Well, we sort of estimate that for patients who are carriers of a BRCA mutation, their lifetime risk of developing pancreas cancer is probably around 6%. Recognizing that the risk of breast and ovary cancer supersedes that. So pancreas cancer is the oft-forgotten number 3 disease in terms of BRCA mutation frequency. And then coming down to the bottom here, PALB2 mutations and their association with pancreas cancer. Series of under 100 patients have suggested that association may be of the order of a couple of %. We actually, in a relatively large series of our own, have not identified a family yet with this. And I think at this time it's uncertain what the conferred higher risk might be. So focusing on BRCA mutations, we said they're rare in the general population in people of Ashkenazi descent. The germline frequency may be of the order of a couple of %. And specifically, we're talking about the foundry mutations, which at least in pancreas cancer, those 3 mutations account for about 96% of BRCA mutations in patients with Ashkenazi heritage. We looked at this at Memorial in 2 different ways. We looked at over 100 patients who'd undergone resection for their pancreas cancer, and then looked at those who had Ashkenazi Jewish heritage, and found that over about 113 patients, 8 had BRCA mutations. And then similarly, we looked at a number of families who had both breast and pancreas cancer, where BRCA hadn't been previously tested, and we found equal numbers of BRCA1 and 2 mutations in that population, about 15%. So it's another sort of clinical hint for not just a personal history of a related BRCA malignancy, but history of breast and pancreas cancer in a given family suggests that there's a reasonable chance of turning up a detectable mutation with therapeutic implications. So to just also mention, because this comes into the treatment, PALB2, this is the partner and localizer of BRCA2 involved in stabilization of the large BRCA2 gene, and also known as the Fanconi N gene. So looking at the treatment perspective, BRCA1 and 2 are involved in double-stranded DNA repair. PARP inhibitors, or poly-ADP ribose inhibitors, are drugs that have established value now in both subsets of patients who are germline carriers of breast and ovary cancer, along with serous ovarian cancer and possibly the triple-negative breast cancer population, although the data isn't looking as strong in that regard. In pancreas cancer, a preclinical model, CAPN1, and this is a BRCA2 mutated line, there's exquisite sensitivity to a PARP inhibitor, and I'll show you this in a moment, and also substantial sensitivity to alkylating agents such as platinum drugs, such as irinotecan, and such as mitomycin. There's a very classic story in the literature of a patient who'd been very heavily pretreated and had been recommended hospice care, and then it was sort of recognized that they possibly had a BRCA mutation, and went on to have really a very productive 8 or 9 months on single-agent mitomycin, a drug that's actually FDA approved for pancreas cancer, but we almost never use it except in this particular clinical setting. And we certainly have some emerging data in pancreas cancer. So this looks at poly-ADP ribose inhibitors, and you can see that these cause single-strand break repairs, which accumulate and cause double-strand break repairs, and then inhibit DNA repair. There's a whole class of enzymes. There's about 17 members of this PARP group, of which 1 to 4 are probably the key ones in terms of cancer therapeutics. And to some extent, the drugs, the PARP inhibitors that are in clinical testing, some are more potent, and others, as has been learned the hard way, are much less potent and probably actually not, in fact, true PARP inhibitors. So this is the hypothesis for why people with germline mutations and a BRCA-related malignancy may have enhanced susceptibility to alkylating agents and PARP inhibitors. If you look at normal cells, DNA repair is primarily by homologous repair. That's knocked out for people with BRCA-deficient tumors, and the alternative pathways are very unstable, resulting in cumulative genetic mutations, instability, apoptosis, and cell death. So this is from some of my collaborators looking at aliparib, or AZD2281, which has been around now for a number of years and in late-stage development in breast and ovary cancer. You'll see here we looked at a number of different cell lines, recognizing, of course, the limitations of cell lines, but just illustrating the point. In the 2 mutated cell lines, there was pretty profound and durable activity to single-agent PARP inhibitor in this preclinical setting. Looked another way, this is just illustrating the difference of how important the PARP inhibitor itself is in terms of activity. This is an example of a very potent PARP inhibitor. You can see it as a single-digit nanomolar range sensitivity in contrast to a very impotent PARP inhibitor. And if you look here, BRCA2 double deletion, you'll see that there's profound sensitivity in contrast to the heterozygous state and to the wild-type BRCA2 gene. And you can see in contrast in the right panel here, if you don't have a decent drug, it's not going to do anything regardless of your state. So this theme is one that's really emerging to understand how well these drugs work. So, a big question comes up. All right, so maybe there are these patients, but where are they and how frequent are they? And we really don't know the answer to that in terms of, if you take an unselected group of people with pancreas cancer, what's going to be the chance that you might find a BRCA mutation and the potential treatment implications? So we don't know. This is a group of patients from Memorial, and I realize you can't read this at all, but it's just to illustrate. We look back for people who'd been tested in clinical genetics, and right there, that's a barrier because most people don't get referred. There are much more stringent criteria in terms of reimbursement for pancreas cancer compared to breast and ovary cancer. And also just the natural history of this disease being shorter, it's usually not high up on the list of priorities as people are grappling with their diagnosis and getting on treatment. So these are some of the barriers that have been encountered. But having said that, there were really two observations that we noted. One, that there was clear activity to platinum agents in this germline population with pancreas adenocarcinoma. 5 out of 6 patients had major partial responses, which would be much higher than you might indicate in a sporadic population. And we also saw activity with PARP inhibitors. There were several trials that we were involved in, and most of these were in combination. One was a single agent, and we saw activity to both combination and single agent. And that's striking to see in pancreas adenocarcinoma activity to a single targeted agent. If you look at the history of trials in this disease, it's anecdotal in terms of activity. So this is an example, and both a patient who's sadly passed, but her son has allowed me just to present this because I think it illustrates some very nice points. This lady, it was a physician, she was actually a psychiatrist, and she had successfully negotiated breast cancer, a radiation-induced sarcoma, and went on to develop pancreas cancer. And that's actually a context in which we're seeing more patients, people who've been successfully treated for breast cancer, and that's a big group that we're seeing in practice. This lady had very symptomatic disease, pain, anorexia, weight loss, and actually had to stop working. And she went on one of our first PARP inhibitor studies and had a pretty dramatic response. I don't know how impressive to you that is, but it certainly was both clinically and radiologically, and by tumor marker profiling went back to work and had disease control for a year plus. So it's not that we don't see this, but it certainly again gives the suggestion that there's a real hypothesis behind this targeting. To date, there are a small number of trials that are underway. Most of them are not focused on pancreas cancer, and most of them are not exclusive to patients with BRCA mutations, but they're looking at defining dose, and this particular study has a small number of patients with pancreas cancer, looking at dose definition, also including patients with endometrial and ovarian cancer. So with that in mind, we've set up a series of trials which are both national and international, and we hope we might have involvement here in Toronto too, looking at veliparib in germline carriers with pancreas adenocarcinoma. Veliparib is also known as ABT888. It's also a highly potent PARP inhibitor. It's an oral drug given on a twice-daily basis. If you're giving it alone, we give it continuously. If you're giving it in combination, we give it for shorter periods of time. And again, very strong preclinical data in BRCA models of other diseases and in pancreas cancer, showing activity alone and activity in combination. And this is the particular trial. This is funded by the NCI, and also the correlative series of questions is funded by a grant from the Lustgarten Foundation. And it's a randomized phase 2 trial in patients with untreated metastatic pancreas cancer, the control arm being cisplatin and gemcitabine, and that's sort of gone out of favor in sporadic pancreas cancer, but based here on the germline carrier point, the use of cisplatin is well justified in this population, and there are a lot of reports now of nice responses in this group. And for the experimental group, the oral PARP inhibitor is going to be added. So this is opened. We have our first couple of patients underway. The first part is just dose definition for this particular combination, and then we'll expand into the randomized phase 2 portion. Just in terms of trying to get an early look, our primary goal is looking at response at 6 weeks, and then we have both a practical design to expand the study if recruitment proves brisk enough, and that certainly may be a challenge. We've also, which I hope we won't have to do, a plan to collapse the study to a single-arm, non-randomized trial if it proves more challenging than we've anticipated. So this is just the statistical plan. And then secondarily, for patients who get allocated to the control arm, or who've got a known mutation and been treated with other lines of treatment, then we're going to look at the activity of single-agent PARP inhibitor in this particular population. So again, this is just starting. We certainly have some clinical data showing single-agent activity, and it'll remain to be seen whether that hypothesis holds in the clinic. There is a suggestion that probably if this activity is real, it's going to be for patients who have not had a lot of prior treatment. So we may end up refining the eligibility criteria a little more. So from the secondary outcomes, looking at safety, looking at disease control, survival, and then a whole series of correlative questions. And in this trial, we're planning to biopsy patients before treatment on the randomized phase 2 portion of it, and also biopsy patients at the time of progression. And this is really to understand in a very thorough way the spectrum of BRCA mutated pancreas cancer, to sort of elucidate methods and mechanisms of resistance and sensitivity to platinum and PARP inhibitors, to look for de novo resistance, to look for reversion mutations. So in the literature in breast cancer, it's been described that BRCA2 can revert to a functional state, and we don't know whether that happens in pancreas cancer or not, but it's one of the goals is to look at this. And then this particular question in that is loss of heterozygosity essential in pancreas adenocarcinoma that arises on the background of a BRCA mutation. We actually hope that this is true, but for the hypothesis that's underpinning the study, but there's some data that suggests maybe there's more to this. So this is a preclinical model, the KPC mice, David Tuveson's mouse model of pancreas cancer, which is a P53 mutated, KRAS mutated pancreas cancer model. And in the Knudsen hypothesis, accepting that there has to be the baseline predisposition with the germline mutation in BRCA, and in the tumor, there's loss of the other allele. But the suggestion from this data is that that actually may not be so in pancreas cancer. And they looked at this from the clinical sense. They looked at a founder mutation in the Icelandic registry population and identified that 3 out of 4 of their pancreas ductal adenocarcinomas in carriers did not have loss of heterozygosity, and that in fact the association of the founder mutation and loss of heterozygosity might suggest delineation along the lines of acinar malignancy, which is a very small and rare subtype of pancreas cancer. We would love to either support or refute, hopefully refute the hypothesis, because it isn't so encouraging for the story of PARP inhibitors in pancreas cancer. So the overall conclusion is that you may not actually have to have that second somatic allele loss, and we'll see. So the biopsies that we take will help us. We actually do have one patient with an acinar cancer and a BRCA1 mutation, and we're hoping to be able to go back and do this retrospectively just on a single individual basis. And so finally, I just leave you with these conclusions, going back to the title, is personalized medicine in pancreas adenocarcinoma. Is that a reality? I think it's possible, and maybe in the coming year or two, as some data from some of these trials that we've alluded to emerge. Right now, we would have to say that cytotoxics are a key component of treatment. We don't have good markers other than how well somebody looks when they walk in the door in terms of prediction. But there is some suggestion that looking at biomarkers of drugs may offer some opportunities for therapeutic refinement. And of course, I mean, a lot of this is going to come from the continued improvement in the understanding of tumor biology and preclinical models, along with continued biomarker development in this disease. And we hope that one day we'll be able to actually molecularly phenotype people with pancreas cancer. And you can imagine, so somebody who has a BRCA mutation, platinum's PARP inhibitors may have a role. Somebody who has a wild-type RAS, we didn't discuss this, but anti-EGFR targeting, spark positivity may predict for sensitivity to nab-paclitaxel, a SMAD4 retention, a more locally confined phenotype to this disease. So we'll see. So thank you very much for your attention, and just acknowledge all the support.
Thank you. Thanks a lot. Are there questions? Yes, David.
A couple of quick questions. First of all, in high-grade serous cancer of the ovary, 20% have germline mutations. If you're looking at functionally or from a genomic perspective, about 50% have some kind of homologous recombination defect, and therefore could respond to PARP inhibitors. So what's the sum total of homologous recombination defects in adenocarcinoma?
That's a very good question. Nobody really knows the answer to that. I mean, people have sort of speculated that maybe it's about 50 to 60%, and that maybe the potential application of this is greater than the germline population. I'm a little doubtful from what we've seen so far in our sporadic trials with PARP inhibitors, but we don't know. We have a small preclinical project that we're collaborating with Myriad in both germline population and in a sporadic population that we're trying to get at this to see if we can sort of identify a group of people prospectively based on their homologous repair deficiency pattern that might predict ability to respond to these drugs. But I think it's a key question.
Mm-hmm. Docetaxel trial, where the docetaxel patients did so shockingly well that even though you got a good response.
We'll be delighted with that. In pancreas cancer, that will be good news. But I think the point is well appreciated, and we actually don't know if there's going to be an incremental benefit to the PARP inhibitor, and that's why we chose to use a platinum backbone as the comparator control arm.
Yes.
First of all, thank you very much for a wonderful overview of both the reality of it and some of the promising developments. I just wanted to understand one summary statistic you had, which was on the Ashkenazi Jewish patients increased with BRCA1 mutations. And obviously, Ashkenazi Jews have an increased frequency of BRCA1 mutations. So therefore, any Ashkenazi Jew with a pancreatic cancer is more likely also to have a BRCA1 mutation. So was that enrichment beyond what you'd expect for being Ashkenazi Jewish?
Not that we know of, but this is something that's really not fully understood in pancreas cancer. So the way most of those patients that were tested were identified were they either had a personal history of a related BRCA-related malignancy, they had an Ashkenazi heritage, or they had a family member who had a BRCA-related malignancy. That was in the 15 patients who had a documented germline mutation and pancreas cancer. And in that group, we saw 4 who had BRCA1, which is a little higher than people had previously thought, and 11 with BRCA2. The other study looked retrospectively at people who had been operated upon and just selected out for Ashkenazi Jewish heritage. And in that group, there were 8 people. So we would love to be able to, then there were two distinct groups, there was no overlap in that. We would love to be able to just screen patients routinely, and actually that was one of the things we were trying to see if we could do to expand enrollment in the study, but it's just both practically impossible and cost-wise impossible, and not least of all, this is an NCI-sponsored study, so people have to have their genetic testing in a CLIA-approved lab, and given the Israel collaboration, it essentially is under the auspices of Myriad Genetics. And for a lot of people, we won't be able to support coverage outside of the clinical indication for the testing in the first place, unless it's known that they're already a carrier.
And so, let me understand. So the cost issue is because it's basically a laboratory fee to Myriad Genetics.
Right, and
could you run it through, sorry for the distraction, but through a CLIA-certified whole genome sequencing lab and then look at that, see what you need?
well, we would love to be able to do that, and that was actually our original plan, but the logistics of that with the NCI, this had to go through the State Department for all sorts of levels of regulatory approval, is that we can't right now, but hopefully this will change and that there will be a more practical way of doing this to facilitate the key points.
Just one more question. You talked about opportunities for screening. I want to know what you mean by that and what you're doing about that.
Right, so we would love to be able to screen everybody who comes in the door to look at their molecular and genetic profile to see whether there is something that we can do therapeutically. That's not feasible at the current time for reasons of tissue availability, for reasons of cost, and for reasons of logistics. And from the clinical genetic assessment, at least in New York, we have to have people see a clinical genetics counselor and have those results conveyed in person. So that's a whole additional layer of work that has to be done in a very tight frame for these patients who are sick and need to get on treatment pretty quickly. So again, I think as the field evolves and people are more aware of this and there's therapeutic opportunities, I think this is going to become, I hope, at least for a selected group of patients with pancreas cancer, reality.
Yes.
So my question is something you actually touched upon but not elaborated in your talk. It's about identifying a high-risk population. Given that the pancreatic cancer is very lethal, that might be a very important aspect of the disease. And when we do know quite a bit about, or we do know a little bit about the pancreatic etiology, and we know the smoking, we know the medical histories, diabetes, pancreatitis. What do you think is the outlook of actually identifying a high-risk population, and what is the missing piece in this puzzle?
Right, so we didn't speak really to this topic at all. It's a whole additional topic, but some of those single gene defects, I mean, you can argue that until the therapy refinements are there, that maybe the most important thing is identifying the healthy family members and that they're potential people that could be screened to try and detect this disease before it becomes an invasive reality. But that's proved, challenging. There, here I know you've a big study, the series of CAPS trials, the ones that we're involved in. I mean, there are a lot of questions in terms of how to screen, what modality, what frequency, what patients to include. I think all of this is an evolving field and certainly, a fascinating area. And I think there probably will be opportunities for a relatively small subset of people with genetically predetermined pancreas cancer where there may be an ability to identify this disease at a pre-invasive state. I suspect for most people where the risks are the unknown quantity, that our ability to do that is going to be, at least in the current age, limited.
Thank you very much. Again.